Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on HealthcareNOW Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Joining me as we cut through the fog that exists at the leading edge of healthcare technology. Our mission is simple. We're searching for beneficial disruption in healthcare from emerging technologies. I'm really pleased today. My guest is Gigi Sorenson. She's the Chief Clinical Officer and Vice President of Operations for GlobalMed. Gigi is an RN and holds a MSN degree. She has a deep background in telehealth, telemedicine, and remote patient monitoring. And that is exactly what I want to discuss with her today. So, Gigi, welcome to the Tate Chronicles.
Thank you so much, Jim, for the invitation. It's my pleasure to be here with you today.
Yeah, I appreciate you sharing your knowledge. I always kind of like to start off, Gigi, with a general question. What spurred your interest in telehealth? How did you get into this area of healthcare?
Actually, my background is in cardiology, and I spent many years in that environment. And as I started to watch how patients were having difficulty accessing care, whether it was getting in for pre-op visits or post-op visits, or being able to maintain a relationship with a specialist that may not be in their area, and they were driving great distances and putting a lot of burden on their family and themselves to get to these short meetings. When the telemedicine started coming around, and our health system that I was working for at the time found an interest in this, I was asked to go and research it and see if it would be something, and it just fit so well my struggles when I was seeing patients in the clinic, and my no-show rate was high because they couldn't get in because of weather or distance. They didn't have money for gas. This was an excellent way to connect patients with their providers so that the patient could stay at the closest point to their home as possible. And then they got the care that they needed consistently, and then their outcomes were better. They felt better, they were happier, more satisfied, and healthier.
Well, you bring up something there, Gigi, that's kind of interesting. You talk about pre-op or possibly post-op healthcare encounters, which sounds like a really perfect use case for telemedicine. But what are some of the other use cases that you see? I mean, you kind of mentioned driving great distances. That kind of makes me think of a rural environment. Is that what kind of you first came up against, folks?
My specific example, yes, was because of rurality of patients to where their providers were. But it's more thinking of it as isolation of the patient. And a patient can be isolated whether they're in downtown New York in a high-rise but don't have any access to transportation, so can't get to their doctors, or don't have a phone available to them, or live in a high-rise building that the elevator's not working and they're too ill to walk down the stairs, versus someone who's living out on the Navajo reservation. So isolation is so individual and defined by the patient more so than geography, but geography is easy to conceptualize when you look at isolation. And so the use of telemedicine can go across the spectrum. It can be connecting providers to other providers for support and guidance. For example, a primary care provider can access a specialist that doesn't live in their area and get the guidance they need on their patients. A patient can access a provider, and geography doesn't matter. You can have patients then also initiating their health care on their own with so many of these what's called direct-to-consumer, where they can essentially get urgent care from an app on their phone. And then the next level is that absolute in-home care, whether it's extending hospital care inside the home, hospice care, or even just chronic care management in the home. So it can run this spectrum of anything to also from wellness to end-stage chronic disease.
Sure. You know, there's one thing you mentioned there that kind of brought some clarity to me. If a patient has an established relationship with the provider, and it's really just going to be a check-in to see how they're doing, review symptoms, things like that. That looks almost like the low-hanging fruit of telemedicine because you're not having to really worry about any new diagnostic things if symptoms are the same and just treating some chronic conditions. That sounds like a perfect use.
Oh, it is perfect use and if you want to drill into a specific application, for example, treatment for high blood pressure. If a patient has a blood pressure cuff at home that the physician or the provider has deemed clinically worthy so that they trust the information coming from the blood pressure cuff, patient can take their blood pressure when they're at home and report those either electronically or verbally when they check in with the physician versus having to drive what could be hours at times in for a 5 or 10 minute visit with the physician, because you don't have to listen to lungs or look at, or touch something or smell something in order to get that follow-up done. So established patient care is perfect. Post-operative care, many times what the surgeon is looking at is the integrity of the wound that was made to fix the joint or take the gallbladder out or whatever it is. And that can easily be done via virtual health.
Just as you speak, I keep coming up with different thoughts about some possible use cases. It's really amazing. And so I know for hospitals, when they discharge a patient, one of the most critical things they want to make sure of, and it really affects their reimbursement, is that patient does not get readmitted for 30 days.
Exactly.
And so most patients are discharged, and hopefully their care goes back to their primary caregiver. But I know there are caseworkers involved with discharge, and are there examples now where there is, even whether it's phone calls or checking in with patients some other electronic way, check their blood pressure or their weight in case of congestive heart failure? Is it being utilized even to keep people from coming back in after that within 30 days?
Absolutely, and that's that whole realm of chronic care management, and we're finally even seeing reimbursement codes come from this, but that is sending patients home with devices such as a blood pressure cuff or a device to measure their oxygen, a scale so they can weigh themselves, and other simple tools that you can put with the patient that many times seamlessly upload that information, that data, and put it on dashboards that care managers, nurses can look at that have alerts attached to them for that individual patient. And so you can catch things early because you have another set of eyes on it. You have alerts that are set for triaging, and you can catch things faster at home right away than waiting for a patient for them to individually decide, should I go in to see the doctor, or can I even get there, so why bother? And so that whole in-home monitoring or remote patient monitoring is a huge industry that's coming with very well documented rates of reduction of readmission, and not only just reduction in readmissions at those 30 days so the health system doesn't face a penalty, but if they do have to be readmitted, it has been shown that their length of stay is shorter, they're less sick because you caught them sooner, and overall satisfaction goes up because you're able to get those outcomes the way you want them to be for the patient.
As far as this post-discharge follow-up by caseworkers with receiving patient data and having dashboards and probably clinical decision support systems, alerting them to patients as they approach risk, are you aware of any particular hospital systems or hospitals that are really at the leading edge of this at all? I'd just be fascinating to know who's really doing this. The hardware's there, the internet's there.
Software, and the software is coming there, yes.
Yes.
And also integrating artificial intelligence into this now, some virtual work into it is all being done. There are many health systems across our country that are doing this and doing this successfully. The program that I personally stood up is in Northern Arizona, Northern Arizona Healthcare. And we were blessed to be able to publish on our work and show all the positive outcomes. But across the country, you're seeing many, many health systems get into this. And also, even just individual payers are getting into it. The insurance companies are offering similar type or limited type programs to this too, to help supplement.
Change the subject just a little bit, but still about use cases. I was reading about some of the work that GlobalMed has been involved with, and it seems like there's some involvement with the military. What's that all about?
GlobalMed is blessed to be the largest provider of virtual care hardware software to the Veterans Administration. We also have what's called an authority to operate, which is the security granted to have our software on the Department of Defense. And we have hardware and software placed in every VA clinic across the country so that veterans can receive their care in a point closest to them, even if their specialist isn't out there. And also we have other types of military. And actually there was a lovely press release done about the placement of our telemedicine unit in the White House. And so our equipment follows the president wherever they go, mm-hmm. and we take great pride in this.
Well, obviously, all the hardware and software bugs have been worked out if it's accepted at those critical points. You know, there are some commercial companies out there where you open your laptop and set up an account and get connected with like electronic urgent care type situation. That's kind of episodic encounters. That, to me, is relatively low-level telehealth because the patient does not really probably have any electronic devices to check their oxygen levels or their blood pressures. Or I know there's. Tell me about some of the hardware devices. I think there's probably some stethoscopes that can be used at a clinic that are, tell me about some of the hardware behind there.
For example, GlobalMed has a camera, and on this camera, different heads can be placed, and so you can do eye exams, ear, nose, and throat exams, wounds, dermatology, and so camera is critical. Stethoscope, of course, is out there. A pulse oximeter, which is a device that measures the oxygen in your blood, is a common one. And then also scales are out there for hardware, spirometry to measure, your efficiency in your breathing.
Oh, sure.
Those are somewhat of the key ones. And thermometers, of course, to look for infection is a key data point.
Going forward, if you put on your or take a look in the crystal ball, 5 or 10 years from now, what type of devices? I mean, it sure would be nice if there was some way to know somebody's hemoglobin, A1C, things like that. Are those devices on the horizon? Really non-invasive, just transcutaneous. Right. Yeah.
And I think all the transcutaneous sensors that are out there, ingestible sensors, are not that far. They're out there already. It's finessing them and validating the data in a little bit longer term. But you see that combined with augmented reality, artificial intelligence, virtual reality, and everything is going to go smaller and smaller to the point of an app on a phone or some type of communication device like that. Routers placed in patients' homes that can assimilate all of this data and then push it up to the cloud where it can go to the provider that it needs to go to. All of this is out there, and patients being able to test their blood in their home so they don't have to go in for blood tests and things like this. That's all. Some of it is here now. It will get perfected over the years with smaller devices, less invasive devices, less costly devices, and all being tied to more and more secure software.
One thing that you mentioned early on, Gigi, is your intense background in cardiology. I imagine there's some pretty sophisticated electrocardiographic devices that can scan, output and pretty quickly say if somebody's having some fibrillation or some other potential problem. I'm sure that's already happening, isn't it?
Oh, yes. There are EKG devices that can run the gamut of straight rhythm strips to full 12-lead EKGs. There are sensors out there that can upload resistance factors for patients in congestive heart failure, that there are point-of-care lab testing specific to cardiac patients, and all of these are becoming more and more sophisticated as time goes. And so, and now even with the cameras and the technology that exists now, that patient who just had open heart surgery doesn't need to, with a very sore chest that has just been manipulated through the surgery, try to get themselves in a car for a bumpy ride to a doctor's office.
Sure. One thing that often affects what direction healthcare goes has to do with reimbursement. And I know for a number of years there's been kind of this back and forth about what will be reimbursed and whether telemedicine will be reimbursed really by Medicare, which is the biggest payer in the United States, what level, and what is going to be the requirements around that. And I'm sure that's going to drive a lot of this. And so what type of, and even whether it's the Blue Cross Blue Shields, what type of reimbursement is available and how's that evolved over time?
Over the years, this has been a slow and somewhat painful journey to watch, but finally we are seeing states pass parity legislation, not only for payment but for reimbursement in regards to virtual health or telemedicine visits, so that they can be seen at the same level as a face-to-face, let me be able to touch you visit. And so this is finally coming. So the majority of states have this passed already. And now we're seeing payers start to follow suit. And then the other extremely exciting is just over the last year now, we have seen CMS come out with multiple codes for expanding reimbursement and developing payment models for telemedicine. And new legislation coming out that is expanding this for in-home chronic care, not regulating it down to the point that only patients who live in ultra-rural areas can benefit from this, that geography stipulation is going away. And we're seeing legislation and that coming down too, so that care can be done in the home. Patients don't have to go to a clinical setting.
That place of service has always been the bugaboo. It either had to be an ambulatory environment or an inpatient environment. So a place of service, of healthcare delivery, actually in somebody's home. I'm going to ask you a question that has always kind of fascinated me. So if I was all these millions of people that are on cruise ships every year, and another large cruise ships have a little clinic with some oxygen and maybe a few devices and a doctor or a mid-level provider, and something happens and they need to reach a specialist and they're at sea, or how do you see any growth in that? Is telemedicine, telehealth being used in that kind of environment, cruise ships?
Yes, it is. And actually GlobalMed has our solutions out on oil rigs, which is very similar. You have large crews doing very dangerous work with very expensive transport off the oil rigs, and being able to leave those individuals at that point of work and life, which happens to be an oil rig, is quite applicable. And so you can even expand that, not just beyond, cruise ships, yes, connecting. International travelers being able to go to their consulate and receive care from an American doctor in different types of this environment. And then you see virtual health starting to expand in third world countries, connecting to other, using extremely limited in-country resources in a broader path.
I'm glad you brought back up GlobalMed. So GlobalMed has a software platform as well as a hardware platform, correct?
Yes, we do.
Okay, and so let's talk about the software platform. Tell me some of the functionality of that. I guess it controls cameras and things like that, runs over the internet?
It's cloud-based. Yes, it can run off the internet, can run off cloud. It works with very low bandwidth, and so our software platform is able to not only control the hardware devices, like you said, camera and all this, but it is code that we have written that allows all of the evidence to be gathered in from the devices that are being used, whether it's a blood pressure cuff or a vital signs machine or whatever it is. All that data can be then uploaded and stored in an electronic medical record type of format, so that can then be placed within a health system's EHR. And so it's not only the aggregation of the data, but then the output of that data where it has to go.
Well, that what you mentioned about low bandwidth, that brings up a great point, because I'm sure in some areas there's not Wi-Fi. It's going to be dependent on a cell phone signal or something that like that, and so it is coded in such a way that relatively low requirements on the data stream, sounds like.
Absolutely, yes. Yeah. It can be Wi-Fi, it can be 3G, it can be satellite. Well, we do it all.
Well, when you mentioned that the encounter is documented or recorded or maybe goes into some type of EHR, how does that happen? Is it just a recording of the visual and the audio, or is there discrete data that's being captured? You have the capability
to do
that?
Yeah, across the board, virtual health encounters, the encounter itself is not videotaped or shared, because you don't do that routinely in your provider's visit.
Exactly.
But all of the data stream that is collected is moved through the cloud into that service providers or health systems or whoever it is into their EHR.
Who for GlobalMed, who are your customers? Are they hospital systems? Are they small practices or large government entities? Who are your customers?
Yes.
All those. Really? So even a small practice could utilize.
Yeah, we run the gamut of single provider practice all the way up to extremely large health systems, into payers that are providing care, into large industries such as the oil industries I talked to you about. Petrobras is the company on the oil rigs. We have a deployment in Argentina that it will be, as it rolls out, be providing online immediate care to millions of people in Argentina. We have a deployment in Zimbabwe where we have placed our portable units in small rural areas so they can stand up a clinic in those areas.
Wow.
We have clinical units and solutions placed all across the Navajo and Hopi Reservation in northern Arizona. So we can, it's all over the board where you can use these.
Exactly, can scale up. We're almost totally out of time, Gigi. I can't believe it's gone by so quickly. I want to make sure that you can let us know how somebody could contact you or GlobalMed to find out more.
Absolutely. We would appreciate it so much. And so at GlobalMed, you can go to globalmed.com as our website. We are based in Scottsdale, Arizona. And my number, if someone would want to reach me, is 480-398-7587. And we would be happy to, if I can't answer your questions, direct you to where you can be directed.
And I personally, I would just love to get a demo. Is there a demo recorded at the website, or we'd have to just set that up? How would that happen?
Sure, absolutely.
Yeah, okay. That kind of brings us to the close here. Thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, Gigi Sorenson of GlobalMed. Gigi, thanks for coming aboard today.
It was my pleasure, and the time did go by very fast.
It really did. You can find more information on this show's program page at HealthcareNOWradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.